Hi, my name's Emily. I'm a family nurse practitioner student, and today we're going to be doing our comprehensive evaluation. Hi, my name's Emily.
Hello.
If you can go ahead and just say your name and birthday.
Maria Gross, birthday 2/13/68.
And where are you?
I am in Mount Pleasant, Michigan.
And what is the date today?
Today is March 23rd.
Perfect. So we're going to start off with our HEENT exam today. So the first thing we're going to start off is by assessing cranial nerve number 5, trigeminal. So for this one, I'm going to palpate her masseter muscles, and I'm going to have her clench her jaw. Good. So muscle strength is equal bilaterally. You can go ahead and relax your jaw and just move your jaw from side to side like this. Yeah, perfect. Go ahead. Good. And jaw movement is smooth and symmetrical. Now we're going to assess all three divisions of the trigeminal nerve using the Q-tip. She's going to tell me if she feels soft or rough, or sharp. Sorry, soft or sharp.
Soft.
Yeah.
Soft.
Yeah.
Soft. Rough. Sharp. 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 Sharp.
Good. Sensation is equal and intact across all three divisions of the trigeminal nerve. So now we're going to move on to cranial nerve number 7, which is facial. I've been looking at her facial movements at rest and with movement, but I'm also going to have her do a few different faces for me. So go ahead and smile and frown. Show me all your teeth. Puff out your cheeks. And then raise your eyebrows. Clench your eyes like this. Good. You can go ahead and open. So normally while her eyes are clenched, I would try to open them, but we're just going to verbalize that. But her facial movements are symmetric with good strength bilaterally. So now we're going to move on to the otoscope exam. So for this one, I would stand next to the patient. I'd be holding my otoscope upside down. I'm going to pull her pinna up and back, and I'm observing her tympanic membranes. They're nice and pearly gray with no visible coning. And so now we're going to move on to cranial nerve number 8, which is the acoustic and vestibular cochlear. So for this one, I'm going to perform a whisper test to assess her hearing acuity. So she's going to tell me what I whisper in each ear.
Cat.
Yep.
Dog.
Good. I'd also perform a whine and Weber test. So the whine test would compare air conduction to bone conduction, and the Weber test would use a tuning fork to hear which ear hears better. But I don't have those materials, so we're just going to verbalize that as well. So now we're going to move on to eyes. So we're just observing her external eyes. I'm looking at her eyebrows, orbital area, and her eyelids. There's no orbital edema, saggy tissue, lesions, ptosis, discharge, or any tearing. Her sclera is also nice and white and clear. Looks nice and healthy. So now we're going to move on to cranial nerve number 2, which is optic. So for this one, we would actually use a Snellen chart to assess her visual acuity to see if glasses or contacts are possibly needed. We'd also assess color discrimination as well at this time. Now we'll do a visual field test though. So for this one, I'm going to take my hand and she'll just tell me when she can start to see my fingers. So just say yes.
Yes. Yes. Yes. Yes.
Okay. So visual fields are intact in all 4 quadrants. If for some reason there was an issue, I'd have the patient cover her eye and again, move my fingers to the opposite ear. So now we're going to move on to cranial nerves number 2 and 3, which is Perla. So we're looking at her pupils for size, shape, color, and equality. So just upon observing her pupils, they're nice and equal, round, and reactive to light and accommodation. At this time, I'd also take my pen light and I'd shine it in her pupils. So I'm looking for a direct pupillary response when the light is shined. I'm also looking for a consensual response in the opposite eye. To test accommodation, I'm going to have the patient follow my finger to her nose to observe pupil constriction. And there is pupil constriction. So now we're going to move on to cranial nerves number 3, ocular motor, number 4, trochlear, and number 6, abducens. So for this one, I'm going to have her keep her head still, and with her eyes only, she's going to follow my fingers as I make an H. And extraocular movements are intact without nystagmus. So now we're going to move on to her convergence. So again, finger to her nose, and I'm going to test for convergence. And go ahead and follow. Good. Convergence is intact. So at this point in the exam, I would do my ophthalmoscope exam. So for this, I would explain to the patient what the exam is, get at the appropriate level of the patient. I would adjust my ophthalmoscope and then also dim the lights in the room a little bit. For testing her eyes, I'm using my right hand for her right eye, my left hand for her left eye. I take my hand and place it just above her eyebrows. So just upon examining her eyebrows, her eye Her orbital, I observe a present red reflex, normal retinal color, no lesions, normal vasculature, so that looks good. For nose, again, we're just gonna verbalize. This we'd be assessing cranial nerve number 1, olfactory. For this one, I would assess nasal patency and sense of smell by using 2 different swabs of smells and having her smell in each nostril. I'd also palpate her maxillary and frontal sinuses, but we're just gonna verbalize that for this part as well. So now we're gonna move on to mouth and throat. So for this, I'm expecting, go ahead and open your mouth, her lips, tongue, gums, palate, floor of her mouth, the nice and pink, moist, smooth. I don't see any like lesions or any ulcers, anything like that. Her tonsils are rated 0. Her teeth are also look good. I don't see any like loose, wiggly, or chipped teeth. So you go ahead and close your mouth. So now we're gonna move on to cranial nerves number 9 and 10, vagus and mouth. So for this one, I'm gonna have the patient say, good. And I observe that the uvula is midline with symmetrical elevation of the soft palate. We also assess the gag reflex by stimulating the posterior pharyngeal wall, but we're just gonna verbalize that. Last thing we're gonna do for cranial nerves is cranial nerve number 12, which is hypoglossal. So go ahead and open her mouth, and then move your tongue from side to side. So her tongue is symmetric with no deviations. Her speech has also been clear. As she's been talking to me, she's been able to articulate her words just fine. So we're good there. We're also gonna palpate her trachea to make sure it's midline. And it is midline. So now we're gonna move on to her lymph nodes. We do this on both sides, but I'm just gonna verbalize one side. So we'd start with her pre-auricular, posterior auricular, occipital, jugular, gastric, superficial cervical, posterior cervical, supraclavicular, deep cervical, submental, and then submandibular, and no lymphadenopathy is noted. I'm also going to assess her thyroid, and as she swallows, assessing for symmetrical elevation. Go ahead and swallow. Good. And she has symmetrical elevation, and I didn't feel any nodules as well. So now we're gonna move on to carotid arteries. So for this one, I would be using the Eval stethoscope, and I'm assessing for any bruits while the patient holds her breath. You can just pretend to hold your breath. Good, and no bruits are noted. So lastly, we're just gonna do our spinal muscle accessories. So the first one, we're gonna assess her sternocleidomastoid muscle. So I'm just gonna put some pressure here, and you're gonna turn your head towards my hand. Good, and we'll do the other side. Good. We're also gonna test her trapezius strength. I'm just gonna give her some resistance as I push lightly on her shoulders, and she's gonna push up against my resistance. Good, trapezius strength is intact. So now we're gonna move on to the cardiac and lungs part of the assessment. We're gonna start with our jugular venous pressure. I have the patient at a 30-degree angle. I can't do that, but normally we would. Again, I'm using that tangential lighting. I have the patient turn her head slightly away, and I'm inspecting between the sternocleidomastoid muscle for any internal jugular pulsations. I don't see any visible jugular distension at 30 degrees, and it's less than 3 centimeters above the sternal angle. We're also going to inspect her carotid arteries, again, looking for any visible pulsation of the carotid arteries in that area, and I do not see that. I'm also going to palpate her carotid arteries one at a time. I'm assessing for rate, rhythm, amplitude, and if there's any thrills. And carotid pulses are 2+ bilaterally, and I didn't feel any thrills. So now we're going to move on to lung auscultations. So for this one, we're listening to all lobes of her lungs. I'm trying to listen for a full inhale and exhale. I'm listening for any vestibular versus bronchial sounds, any adventitious sounds. It is best to do this on the bare chest, but obviously for patient privacy purposes, we will keep the shirt on. So I'm just going to listen to your lungs. Just go ahead and take a big inhale, or not big, just an inhale and exhale as I move my stethoscope around. I'm just going to switch this to the diaphragm. Inhale. Okay. Quite nice though. And breath sounds are equal and bilaterally, and I didn't hear any adventitious sounds. So now we're going to move on to our heart sounds. So we're going to listen at the 5 spots. So the aortic, which is the second intercostal space on the left, pulmonic, which is, aortic, which is the second intercostal space on the right, pulmonic, which is the second intercostal space on the left, herbs, which is the third intercostal space on the right, on the left, tricuspid, which is the fourth and fifth intercostal space on the left, and then mitral, which is the fifth intercostal space at the midclavicular. At S1, we'd be listening for tricuspid and the mitral valve closure. At S2, we'd be listening for aortic and pulmonic valve closure. Also listening possibly for S3 and S4 and any murmurs. If for some reason I did hear any murmurs, I'm going to try to distinguish if they're systolic or diastolic, rated in intensity on a scale of 1 to 6, and then also shape, location, quality, pitch, if I'm able to hear that. So we'll go ahead and listen to her heart. And S1 and S2 are present with no extra heart sounds or murmurs. If I was for some reason to hear something, I'd want to listen to her apical pulse for at least 60 seconds. So now we're going to verbalize arterial versus venous disease. So for arterial, cool, pale, pulselessness, shiny, hairless legs. And then for venous, warm, edematous, brown, discoloration, and aching legs is what we'd see for those. Okay, so now we're going to move on to abdomen and her muscle part of the exam. So I'm actually going to have you lie down. Perfect. And we'll just adjust that pillow. Does that feel okay?
Yes.
Okay. So first we're going to start with our hernia check. So for this one, we're inspecting the epigastric, umbilical, and inguinal areas. So I'm just going to palpate. As I'm palpating, I'm going to have you cough and just let me know if you feel any pain, okay? Cough, 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 cough. Any pain when I press there?
No.
Good. Okay, so now we're going to go ahead and auscultate and percuss. So first we're going to auscultate all 4 quadrants using the bell and the diaphragm. For the epigastric and umbilical, we're listening for that venous hum, and then we're also listening for the aorta, and then the bilateral renal, iliac, and femoral arteries. So we'll start with the diaphragm, because that's what we're already on. And that sounds good. Now we're gonna go ahead and percuss all 4 quadrants. So I'm just gonna kind of like tap on your belly. Good. And then I'm gonna palpate her femoral pulses. And those are rolled 2+ bilaterally. So now we're gonna go and palpate her abdomen, and I'm just feeling for any masses. Good. So now we're gonna move on to our special abdominal test. First, we're gonna do our Murphy's sign. This attests for cholecystitis. I'm gonna come on this side, it's a little bit easier. I'm gonna put my hand right here, and then I'm gonna have you take a big inhale, and as you do that, I'm just gonna kind of like press my fingers under your ribs, and I'm feeling for that gallbladder. Good, I inhale. Any pain when I'm pressing there? No, good. So that would be a negative test. Our next 3 tests test for appendicitis. For the first one with this, we're gonna do our McBurney's point. So for this one, I'm gonna press down in this area. When I take my hand away, let me know if you feel any pain.
No.
Okay, good. Our next test is our psoas sign. So I'm gonna have you pick up this, like kind of like flex this right leg up. Like that. Any pain in that right lower quadrant?
No.
Good. Last test we're gonna do is our obturator sign. So we'll bring her leg up. And I'm just gonna put some internal rotation here. Again, any pain in that right lower quadrant?
No.
Good. Okay. Next test we're gonna do is for our kidney CVA tenderness. If you wanna go ahead and sit up and face towards this brick wall, I'm just gonna feel your kidneys. Let me know when I like press like this if you feel any pain, okay? Any pain there?
No.
Okay, you can go ahead and lay back down. Okay, our next test is for our meningeal sign. So first we're gonna do our Badinsky test. For this one, I'm gonna have the patient I guess I'll actually move the pillow for this one, I'm sorry. Go ahead and flex your neck up like this, and I'm observing if either of her legs rise, which they don't, so the Berdinsky tide is negative. Okay. The next test we're gonna do is our Koenig sign. So for this one, we're gonna bring the leg up. Sorry. Yep. Go ahead and put this leg down. I'm just gonna flex this leg up. Yep. Then I'm gonna straighten. Any pain along the back side of your leg?
No.
Good. And we'll do the other one. Any pain along the back side of your leg? Good. So her Koenig test is negative. Now we're gonna move on to her knee special test. First, we're gonna start with our McMurray test, and this test for a meniscal tear. So for this one, again, I'm gonna have you flex this leg up. I'm gonna apply some tibial rotation. As I'm doing this, I'm obviously, if the patient tells me she has any pain, but also listening for any clicks in that meniscal area. Any pain? No, good. And I don't hear any visible or any audible clicks. The next test we're gonna do is our vagus and varus test. Varus test for LCL injury and valgus test for an MCL injury. So we're gonna go ahead and bring this leg up again. So for this one, I'm gonna put some pressure on the inside of her leg. This is our varus test, and we're assessing for any pain on the lateral side. Any pain on the outside of your knee?
No.
Good. We'll now do our valgus test. Any pain on the inside of your knee?
No.
And then I would do the other leg as well if there is a possible injury on that one. Our next one is our interior and posterior drawer test. So you're gonna actually bring this leg up, and I'm just gonna kind of like gently sit on her toes. I'm gonna cup her knee and bringing that tibia forward to see if there's any dislocation of the ACL or PCL. And good, that's intact, so no ACL or PCL tear. All right, I'm gonna have you stand up, and let's move this little bit out of our way. So we're gonna do our scoliosis test. So if you just wanna go ahead and stand with your legs together, yep, and go ahead and bend down, knees locked, arms aligned, perfect. Her spine is nice and straight. I'm not observing any scoliosis. So you can go ahead and come back up. Our last test we're gonna do is a duck walk. Sorry, I can demonstrate for you. So you're gonna walk forward, back, and then side to side. Okay. So walk forward, yep, and back, and then side to side. Good. Any pain there? No. Okay, thank you so much. And thank you for